You would think after 2 years the Zoom buttons would come naturally, right? But so as I was saying, I am Rebecca Melendez, Program Director with the East Los Angeles Women's Center. My role is to oversee the services offered at LAC USC Medical Center by our agency. For those of you attending this meeting for the first time, just a tiny bit of background on our organization. The East Los Angeles Women's Center was founded in 1976 by community volunteers who established the first bilingual sexual assault hotline in the nation. Today, we're recognized as the leading voice for thousands of survivors. We provide culturally responsive services specifically for Latina communities in the areas of sexual assault, domestic violence, HIV and AIDS, and an array of services that interconnect. If you'd like to learn more about our organization, you can visit our website at elawc.org. Every other month, we meet to provide you with resources and educational sessions that will enhance our work with survivors. While we miss seeing each of you at our in-person networking meetings, we're excited to have you join us this morning. Just a few housekeeping items. As I mentioned, this session is going to be recorded, and then it will be shared with each of you afterwards for your reference. Ruth Rivera, Program Coordinator at the Wellness Center, will be monitoring our chat today. She'll be on the lookout for any questions that you may have for Dr. Dossett. So October is Domestic Violence Awareness Month. It is for this reason that each October for this meeting, we choose a domestic violence related topic. And so with that, our agency became familiar with Dr. Dossett when we co-located at LAC USC Medical Center at the Wellness Center. We're proud to say that what we've learned of Dr. Dossett in the last several years is that she's a true champion for survivors of domestic violence. It is for this reason that I am so very proud to introduce you to Dr. Emily Dossett. Dr. Dossett is a reproductive psychiatrist and the founder and director of the Women's Mental Health Program at Los Angeles County University of Southern California Medical Center, a novel service approach that integrates obstetrics, psychiatry, pediatrics, and integrated care model for mood and anxiety disorders across the prenatal spectrum. From 2019 to 2021, she served as the first medical director of women's health and reproductive psychiatry for the Los Angeles County Department of Mental Health, the largest public mental health system in the United States. Dr. Dossett is a frequent speaker on prenatal mental health issues and has served as a member of numerous policy advisory groups, including the American College of Obstetrics, and I'm totally butchering this word, by the way, and gynecology's expert group on maternal mental health, and the State of California Assembly Maternal Mental Health Task Force. Her research interests include access to high quality mental health care for prenatal people in the safety net. With that, Dr. Dossett, let's see.
Hi.
Make sure that everything's, the mic is working, the
Everything's
screen is
working.
showing.
Everything's working, yeah, for sure. Good morning, everybody. Can everyone hear me?
Yes.
Okay, awesome.
The floor is yours, and thank you so much for being here.
Thank you for having me. I've been looking forward to this. So Rebecca gave me a lovely introduction, but she's kind of the rock star in the room. We've worked together for a long time, it feels like, because the women that we work with, unfortunately, have a pretty large circle of overlap, which is one thing we're going to talk about today. You know, when I work with women who are pregnant and postpartum and struggling with mental health concerns, very, very, very frequently, there's either domestic violence going on, there's been domestic violence, or there's been some sort of sexual assault in that woman's past or present. So Rebecca and I have a long history of sharing frantic emails back and forth to try to get these women connected to services. And I'm pleased to have gotten to know Ruth as well through this process of getting the presentation set up. So I have a fair amount of time here to talk. I do have a PowerPoint, but instead of saving questions for the end and kind of a standard Q&A, I'd like folks to feel free to ask questions all the way through. And Ruth is going to keep an eye on those. And then when we've gotten to a point where we feel like, it's kind of a critical mass, she'll jump in and ask me questions. And we'll just go from there. Before I move forward, I am going to be talking at the end of this presentation about an organization that was not in my bio, but that I've been a part of and am becoming a part of again, which is called the Mama's Neighborhood Program. And I'll be talking more about that. But when I was looking at the list of attendees, I saw several of the Mama's Program folks here on the call today. So I'm really, really glad you guys are here, and I will probably embarrass you and call out your names at the end of this talk. I also went to my 25th college reunion this weekend, and I talked more than I have in like a year and a half. And so if my voice gets a little wonky, I apologize. Okay, so let me share my screen. All right, does everyone see that in full screen? Yes, just give me Ruth is nodding. Okay, cool. So I know it's there. All right, so IPV, intimate partner violence, mental health and pregnancy, opening the window of opportunity. And I want to emphasize that throughout this conversation, because as hard as this is to talk about, and as many women suffer, pregnancy and the early postpartum are actually a window of opportunity where a lot of women are open to making change in a way that they may not be during other times of their life. So that's hopefully a point that you'll come away with, and hopefully feeling even a little bit optimistic. I want to talk first about women that we see. And Rebecca, kind of gave the formal bio. Just to say a bit more about what all that actually means is I'm a psychiatrist. So I went through med school, I prescribe medications, and my area of expertise is really working with women who have psychiatric issues during times of reproductive change. So I work in psychiatry as well as in OBGYN, though I'm not an OBGYN. You don't want me anywhere close to a pap smear or a C-section or anything like that. But I do work with those women on a very daily basis, really. And our clinic is actually located in the OBGYN suite. So when women come in for their prenatal care, we actually see them in that setting. We see them in the little room with the stirrups and the model of the baby and like the whole deal. So we really try to be right there where the women actually are. And then we also extended the program several years ago into pediatrics, so that as women kind of graduated, if you will, from OB, they could continue to get their care in a setting that they regularly attended, which was basically care for their infant. So we also have an arm of the program that we call the New Family Care Clinic that's in pediatrics. So when I first started this work, which has been a minute now, one thing that just struck me over and over and over was how much trauma these women had been through and how much abuse there was. And one of my residents several years ago did kind of an informal survey. I don't have these statistics in the slideshow because they're not, studied enough to really put them out there in print. But basically, let me actually put this in the chat. How many women do you think we work with? And this is County USC. These are women who are on Medi-Cal, may have been uninsured prior to pregnancy, who have either current domestic violence, previous domestic violence, or a history of some sort of abuse in childhood or adolescence. What percentage of women would you guys guess? You can throw it in the chat and then I'll have Ruth read out the answers. I see the chat numbers ticking up, so. Okay, I'm seeing the answer.
Okay, it's 75% seems to be one of the higher numbers that people are saying. 65, 68, 80%, 70% as well, 58, 85 as well. So those are, but 75 seem to be like the most common.
Okay.
Mm-hmm.
Yeah, so you guys are actually very well informed. So the number was 83%. And that like blew my mind. And when I say that to most people, it blows their mind. So I'm actually glad to know who I'm talking to here. You guys know what's up. So yes, these numbers are extraordinarily high. And I just wanted to tell a couple of little vignettes about what we see in particular in pregnancy, to sort of frame the conversation. So these are just, 3 women out of those 83%. One was a woman we worked with, it's probably 5 years ago now. And the reason her story stuck with me is because she was from another country. Her husband was another country and from another country. And they met here, dated here, married here. And he quickly became abusive. And she really wanted to go back to her home country, but he would not permit her to get passports for their children. And that became a huge legal issue. And she was forced to stay here and actually in a relationship with him because financially she didn't have anywhere to go, basically, in order to be with her kids because she could not get legally, could not get them out of the country. And that was a heartbreak. We worked with her the whole pregnancy and postpartum period, and it was felt very stuck. Another is a woman who's come into our clinic more recently. This is her 5th pregnancy. She has 2 living children who have been adopted out. Her 3rd pregnancy ended in a stillbirth, which was a heartbreak for her. She actually began using drugs pretty seriously, got pregnant by a fairly abusive partner who, in her 6th month of that pregnancy, and this was a pregnancy she really wanted after the stillbirth, he kicked her in the abdomen. She lost the baby. And now she's pregnant again. She did use drugs for the majority of this pregnancy, but she's on treatment, she's clean, and she's really hoping that this pregnancy works out. And then a third is we had a young woman yesterday who came in who is 21 years old. This is her 3rd pregnancy. The first baby was adopted out in a closed adoption. The second baby is only 10 months old, and now she's 10 weeks pregnant. And every one of her relationships has been marked by violence. She was abused growing up, and she came to us yesterday so thin, so frail, and really wants to leave this particular partner, and probably would have done it yesterday, but had left the baby home with him, and she wasn't about to go anywhere without her child. So we have a plan. We'll see what happens. Rebecca and Ruth were on the phone with us, helping us figure this out. But she is definitely still someone who we're working with actively. But the bigger question in my mind with her is, if you're 21 and on your 3rd pregnancy and everyone has been in an abusive relationship, where is the point of intervention so that cycle maybe doesn't occur again? So, having gone through hopefully what's a little bit illustrative of what we see and what you see, I know I'm not telling you anything you don't already know. I'm just hoping to shed a little light on the mental health side of it in pregnancy. I'm hoping today to describe a bit more the relationships between IPV, mental health, and pregnancy in the postpartum, which we call the perinatal period. I'll go more into that in a moment. To illustrate the disparities in rates of IPV and perinatal mood and anxiety disorders, racial and ethnic disparities, financial disparities, and hopefully to outline some points of prevention and intervention to break these cycles and help to strengthen families. So when I started preparing for today, it took me a while to get my head around this, because these 3 situations / conditions are so intertwined. It's almost impossible to splice them out, right? And the 3 conditions are basically pregnancy and the postpartum, intimate partner violence, and mental health challenges. And they are in this cycle where each one acts on the others, right? And I'll talk more about that in a moment. And so what was really striking is how the risk factors for intimate partner violence are basically the same as the risk factors for mental health challenges in pregnancy and the postpartum, and how pregnancy and the postpartum increases the risk of mental illness, as well as the risk of intimate partner violence, and how intimate partner violence often begins or is worsened in pregnancy and the postpartum, and how IPV naturally leads to all sorts of mental health challenges. So these three things are so linked together that the points of intervention, the points of prevention that we'll talk about in the latter half of this conversation are really about trying to break the arrows at some point in this cycle, but really just addressing one of the three doesn't necessarily work. We have to be thinking about all three together. So I'd heard all through my training and all through my career that IPV increases mental health challenges. And there are a lot of studies on this, and just a lot of research that's been done. And it just seems like, to me, that's obvious. Like, yes, of course it does. And what seems to sort of be the going statistic is that IPV increases mental health challenges about threefold. So your risk of having some sort of mental illness is 3 times higher if you are dealing with IPV as well. And this is specific to the perinatal period. And those mental health challenges are, wide ranging. So depression, anxiety, psychosis, post-traumatic stress disorder, those would be more formal diagnoses. And then there are psychological repercussions, right? The inability to trust other people, self-harm, such as cutting, substance abuse, etc., as well as risky behaviors. Sometimes these mental health challenges manifest in the body. They manifest as chronic pain. And that is not to say that pain is quote unquote all in one's head. It means that the pain is real. That's very linked up with the mental health concern. And then there are very real health conditions, metabolic, which means things like obesity, high blood pressure, diabetes, and then cardiovascular or heart conditions as well. So IPV really does increase mental health challenges, as well as you can see some physical challenges as well. And then the perinatal period itself increases IPV, okay? And there are a lot of theories about this. Why would this be true? Is, the partner in the relationship threatened? Is the woman more vulnerable? Is there a power shift? It's hard to say. It is true that the majority of perinatal women with IPV did experience it before they got pregnant, but up to about 25% of women who experience IPV first experienced it when they were pregnant. So pregnancy is a high-risk time for this to begin. And even if IPV was going on before, the violence side of it does seem to escalate in pregnancy. So clearly pregnancy is a time where women are vulnerable to IPV, either beginning or getting worse. So I wanted to take a moment to talk about what are called in my field perinatal mood and anxiety disorders, or PMADs. And these are kind of the mental health concerns that come up when a woman is pregnant or postpartum. And I'm going to be referring to this phrase frequently throughout the conversation, and it's one that you may hear more and more. So I'd like you to be familiar with it. Those of us who do this for a living try to use the word PMAD instead of postpartum depression, because postpartum depression is often what you see and hear, and that's great because we talk about it more than we used to. But there's a lot more that goes on than just postpartum depression. So the word perinatal is a much wider time frame. So perinatal means any time from conception, right, through pregnancy, labor and delivery, and up to 1 year postpartum. So instead of just being postpartum, like depression, postpartum depression, perinatal means that whole almost 2 year period. And the reason that's important is because so many mental health concerns either begin or even predated pregnancy. And if we ignore pregnancy, then we're missing a lot of what can actually affect a woman. The mood and anxiety piece is broader than just saying depression, right? So mood obviously means depression. It also means bipolar disorder, which is much less frequent, but can happen. And then the anxiety piece is so important because actually more women experience anxiety in one form or another than experience depression. And all too often, I've seen women come in who didn't feel depressed, but they felt very, very anxious, but didn't think that that counted because they'd never heard of that before. They'd only heard postpartum depression. So trying to change the language about this is important so that more women feel that they are included and that their experience is part of what we're trying to deal with. It is important to note that just because something is perinatal doesn't mean it only happens in pregnancy or the postpartum. Lots and lots of women who have PMADs actually have chronic mental illness. And this is actually really more the women I see. It's women who've struggled with mental illness either chronically or on and off, often since their teenage years, and then they happen to get pregnant on top of it. And then there are a subset of women who were fine before and have this new onset of a mental illness in pregnancy or the postpartum. If it is an ongoing or chronic mental illness, it often worsens or shows new symptoms, particularly in the late pregnancy or the postpartum. And here's one kind of outline of the rates of perinatal mood and anxiety disorders that do show up. So about a quarter of women, 27% of women, actually experienced whatever the mental health concern was before they even conceived. Another third have new symptoms in pregnancy, often towards the end, towards third trimester, but not exclusively. And then about 40% experience it in the postpartum. So I just really want to emphasize this because it kind of flies in the face of this cultural understanding that we have that pregnancy is this happy-go-lucky and wonderful time for everybody. There's certainly women who don't feel that. And when they don't feel that, but they see this cultural kind of idea all around them, they feel very ashamed and they feel very guilty, as if from the very beginning, they are, a bad mother, and they don't often want to talk about what's going on. So being aware of this as providers and as folks who interact with these women is really important. Okay, so what do PMADs include? Basically, any mental illness that can happen at any time in a person's life, male or female, pregnant or not pregnant, can happen in pregnancy. So that can mean depression, that can mean anxiety, including generalized anxiety disorder, panic disorder, what we call OCD, phobias. It can mean post-traumatic stress disorder. And sometimes PTSD is pre-existing from previous experiences. And sometimes labor and delivery can actually be the trauma itself. If women don't feel heard, if they feel like their pain is not being addressed, if they feel like they're going to die or their infant's going to die, there's a certain percentage of women that can actually develop PTSD from the labor and delivery. Bipolar disorder, somewhere between 2 and 4% of the population has some form of bipolar disorder, and that certainly includes pregnant and postpartum women. And then psychotic disorders such as schizophrenia. Women of childbearing age absolutely get schizophrenia. There's only one diagnosis that is completely unique to the perinatal period, and that's something called postpartum psychosis, okay? And what that means is a psychotic episode that happens because of childbirth. Childbirth is the triggering event. And this is something that is rare. It happens in about 1 in 1,000 deliveries, but it can be very dangerous. About 4% of women who experience postpartum psychosis actually go on to commit infanticide or filicide. They kill their child, and 5% commit suicide. So if you hear about mothers in the media who have murdered their children, there's about a 95% chance that it's actually postpartum psychosis. Unfortunately, and this happened again in May when the young woman in Reseda killed her 3 children, the media calls it postpartum depression. And that just, perpetuates the stigma around postpartum depression. And I'm happy to answer more questions about postpartum psychosis at some point if you guys have them. I just didn't want to spend like hours talking about it this morning, but I could. And then, of course, any of these can have co-occurring substance use disorders, right? And we're going to talk more about that in a few minutes. But when women come to you and they talk to you, right, whether you're law enforcement, whether you're a DV provider, whether you're a mental health clinician, they don't come in and say, I have generalized anxiety disorder, moderate, recurrent, right? Whatever. They say, I don't feel like myself. They say, I feel like I'm on an emotional roller coaster. I feel numb. This is a big one. I thought I would feel happy. I just feel numb. We had a woman not long ago who said, I'm broken. I just don't feel any love for my baby. And that was extremely anxiety producing for her. No matter what I do, I can't relax. I can't sit still. Even when the baby's sleeping, I can't sleep. That's something we worry about quite a bit when women cannot sleep. I feel guilty and I'm a bad mother. And then these last two make me very concerned for things like suicidality. My baby doesn't like me. Everyone else, my baby likes everyone else more than me. Or if a woman says my baby or my family would be better off without me. So these are catchphrases that if you hear, pay attention. Don't minimize. Don't say, the worst thing you can do is say, oh, no, I'm sure it's fine. Oh, you're a great mom. Oh, it's okay. It'll get better. You know, the best thing to say is just tell me more. Tell me how you're feeling, you know, and move forward from there, but don't minimize. So why don't I see if there are any questions there? Because I'm going to start talking more about IPV and PMADs together. I just wanted to do an overview of PMADs first.
There was one question that we had from Heidi, and it was, how long is the postpartum period?
So that's a really good question, and it completely depends on who you ask. So if you ask the, you know, I'm sure you guys are, I don't know who all is in the audience and what you guys all do, but if you're a mental health provider, you're probably familiar with the DSM, right? The Diagnostic and Statistical Manual, which has all the different diagnoses kind of defined. And for the DSM, it's actually 4 weeks, okay? If you talk to the people who will pay for your family leave or your unemployment, it's 6 weeks. And if you talk to someone who actually does this work, it's a year. So as a reproductive psychiatrist, people who do, you know, perinatal work, we fully up to a year. That is because most cases of depression actually come to our attention between about 3 and 6 months. And actually, I'm going to talk about suicide a little later on, but most cases of suicide happen between 6 weeks and 1 year postpartum. And then there are studies that go out 3, 4, 5 years after a woman's had a baby, and the depression untreated can last that whole time period. But in general, when I think about PMADs, I think about 1 year postpartum.
Emily, while this isn't a question in the chat, I do have to let you know that my personal cell phone is blowing up right now. People saying, oh my God, this was me. Oh my God, this sounds so familiar. Oh my God, I can totally relate to this. So it's interesting how not discussed this conversation is, right? Yeah.
I didn't do my triggering caveat. I'm sorry, guys.
Oh no, this it's totally fine.
No, I know. It's just, I just get so mad. Like, why don't we talk about this? There's so many people who just experience it. Let me tell you right out of the gate. I'm going to give everybody 2 resources, and let me see if I can even put them in the chat myself here. I will. Okay, so there are 2 resources I'm going to just put in here. Don't go look at them until I'm done talking. But the first is called Postpartum Support International, okay, or postpartum.net. They have a helpline that is everywhere in the country. They have resources in English and in Spanish. They have calls for dads. They have written materials. That's a great resource, okay? Then there's a group more local to Los Angeles called Maternal Mental Health Now. It used to be the LA County Perinatal Mental Health Task Force, but they changed their name, thank God. And it's, I think it's just maternalmentalhealthnow.org. They have an online directory that you can put in, like, you just go to that website, it says like get help or something, you click on that, and then you put in zip code, street, you know, town in LA County, and it comes up with providers sort of in the area. So I'm putting those 2 in, and Maternal Mental Health Now is actually in the process. They just got a big grant to like update that and put it on an app called Streetwise, which I think will be a little bit more user-friendly, but for now, that's what we have. Having said that, COVID upended everything, so I'm not sure what resources are actually still available, but at least you can have those two. Okay, so let's talk about, I think this is really, 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 really important that when we're talking about risk factors and we're talking about effects and we're talking about interventions of both IPV and PMADs, the best way, the easiest way for me to think about it is that the underlying experience of both is stress, right? No matter what mental illness you have, it's incredibly stressful. And of course, being in an IPV situation is stressful. So if you think how you feel when you're really stressed out, and you feel it in your body, you feel it in your mind, you can't sleep, it's hard to focus, you're not motivated. That feeling of stress is what really underlies a lot of both of these situations. So having said that, I went through and I was looking at all the risk factors, and this was really striking to me. So look how many risks, and of course there are a bazillion risk factors, but the ones that have kind of been studied and come up again and again, look at the long list and how they overlap for PMADs and IPV. So the first are socioeconomic stressors. And a lot of that has to do with finances, poverty, unemployment, low education, which is the next one down, just this feeling of being stuck in a cycle of not being able to provide for yourself or your children what you need. Being young, being separated or unmarried, having a lack of social support. And it's really important to remember that being surrounded by family does not mean that you have social support, because family can be wonderful. Family can be a mixed bag. I have lots of women who tell me, oh, my mom will drive me to my doctor's appointments, but she criticizes me the whole time, right? So it can be physical support, emotional support, neither or both. Fractured communities, right? I see a lot of women who are very isolated because for whatever reason, they, let's say, moved to LA because their community back home fell apart or they didn't feel a part of it. They move here and they're part of a community that is very fragile. They don't feel like they have a place to go. Substance use or abuse, which is both a risk factor and a consequence. And then the trauma history. It's just, I mean, that's a whole other conversation, and I'm sure you guys have had it in other meetings. For PMADs, having a history of mental illness is a huge risk factor. And for IPV, having a history of abuse or other IPV situations is a risk factor. But that overlap is just tremendous. So let's talk about what the stress of the PMADs plus IPV does to the pregnancy, the mom, the infant, the child. And I think this is really motivating for me, because a lot of why I do what I do is because I want the next generation to be healthier. And I'm sure that for a lot of you who work in this field, often your heart is with the children who are kind of caught up in these situations. So if a woman is struggling with PMADs and or IPV, it's pretty common that there's late entry or having a hard time adhering to prenatal care, right? And the less one is able to engage in prenatal care, the worse the birth outcomes are. It's harder to engage in self-care. It's harder to exercise. It's harder to get proper nutrition. It's harder to really do anything other than feel stressed out and just kind of trying to survive. There's an increased risk of maternal substance use, particularly marijuana, which I'll get to momentarily, as well as tobacco. Preterm delivery, which is the #1 cause of infants dying and children having chronic medical conditions, is very much a consequence of having untreated mental illness as well as IPV. Low birth weight, very similar. Lots of medical issues that come from that, and again, comes directly from some of that stress. So this gets a little wonky, but I think it's really important to know. And the reason why is because a lot of women still, and a lot of people in the world, even providers, think that depression is all in your head, or anxiety is all in your head. And that somehow the mind and body are really separated, right? But what we know is that the stress of PMADs and IPV physically has very real effects on the fetus. And here's what happens, right? So you've got this little tiny nugget of human inside you, right? If you're pregnant, and it has its DNA, it has its genes. And we used to think that those genes just kind of made proteins, and the proteins made the human, and the human was born, and that was it. It was all about the DNA. What we've learned over the past 15 to 20 years is that the way that those genes turn into proteins, the way they're expressed, depends on what's going on around it, specifically in utero, right? That's the infant's environment, is the mother's uterus, right? And if a woman is dealing with tons of stress, there's a shift in the chemicals in her own body, particularly her stress hormones. Those stress hormones can cross the placenta, go into the uterus, and actually affect the fetus. And this is particularly problematic if that happens during the 9 months, when the fetus is developing its own stress management system, the parts of its own body and brain that eventually will help it regulate stress as a child, an adolescent, an adult. So that exposure to the mother's stress hormones can cause that stress management system essentially to develop abnormally. And the infant can then be born with a lifelong vulnerability to anxiety, less resiliency, inability to regulate emotions. Now, that doesn't mean that every person who's dealing with a PMAD or IPV is going to have a child who's anxious and prone to being less resilient in the face of trauma, because parenting helps, the actual genes help. There's a lot of other things that can overcome this. But it does look like about roughly 15% of childhood anxiety, and interestingly, ADHD, attention deficit hyperactivity disorder, can be attributed to prenatal exposure to maternal anxiety and depression. So when I talk to women, I don't go into all this, but what I typically say is, think about how you feel when you're stressed, right? And people can't deny what's they feel in their body. People can deny what's in their head, right? But people can't deny what's in their body. And they'll say, oh yeah. And I'll say, now imagine your baby feeling that way. And they'll go, oh yeah. And then that really helps them understand how important it is for them to be mentally well. So once that baby's born, if there are PMADs going on, if there's IPV going on, and there's a stressful environment, that can interact with that child's relationship with their primary caregiver, which is usually, but not always, the mother. And that relationship between mother and child, particularly in the first 3 years of the child's life, sets the tone for all the relationships the child is going to have later in their life. And this has been proven over and over and over and over and over in psychology. That relationship is characterized by what we call attachment, right? And attachment means, a secure attachment means the child feels safe, loved, like their emotions are being reciprocated, like they know they're going to be cared for. It's what you see when you see a mother cooing and smiling at her baby and the baby is smiling back. It's what you see when the baby's crying and the mother looks concerned and picks the baby up. The child learns how to be in a relationship because of the mother's healthy emotional response to it, right? That is secure attachment. PMADs can get in the way of secure attachment, and IPV can get in the way of secure attachment. And there's a lot of conversation now around ACEs. You guys are probably familiar with ACEs, adverse childhood experiences. ACEs can get in the way of childhood secure attachment, right? And there are actually PMADs and IPV that are ACEs, right? So one ACE is having a parent or caregiver with mental illness. One is having an alcohol or drug abuser in the household. One is having a mother or stepmother who was physically abused, right? So this connection between the primary caregiver having a PMAD and or IPV, being then emotionally unavailable to provide the nurturing the child needs for secure attachment, then creates this adverse childhood experience that stays with the child really forever. So it's in utero, and it's also after delivery that PMADs and IPV really can affect the child's mental health. So what do we see? What's actually been measured? Kids exposed to both PMADs and IPV have delays in cognitive development. They walk and talk later than other children. They have learning difficulties. Specifically, they can have delayed reading, other difficulties with schoolwork. Behaviorally, they have sleep problems, temper tantrums, and aggression, hyperactivity, right? And then these kids get diagnosed with something and labeled with something, and off we go. Neurologically, this is interesting. Teenagers who were exposed to PMADs when they were very young children have EEGs, measure brain waves, have brain waves similar to those of depressed adults. So it's actually making physiological changes as the child's brain develops. And what about impact on parenting? Just the stress and the preoccupation with the mental illness or the IPV can impair the parent's ability to manage the health and safety of their child. Things like back to sleep guidelines, using car seats, covering up electric sockets. Women dealing with IPV and PMADs have half the rates of breastfeeding as women who don't. It's hard for people to follow preventive health advice, to actually get to the pediatrician, and to engage in enrichment activities like reading or taking your child for walks. Those things take time and energy. And women struggling with PMADs and IPV may just not have the mental or emotional resources to make that happen. PMADs can also affect the father's perception of the relationship and be a really significant factor in friction and divorce, right? And it's also been shown that PMADs can themselves increase the risk for domestic violence. They cause a lot of feelings of grief and loss in the family, including older children, including extended family. So it's not just the mother that we're talking about. One of the most significant concerns, though, for the mother, and this is specifically around PMADs, but there is a link to IPV, is that suicide in the postpartum, depending on the study that you look at, is either the first or second leading cause of death for women in the first year after they have a baby. Okay, so I just say that again. Suicide is either the first or second, depending on the study, leading cause of death in women for the first year after they have a baby. And this particular report, where these stats come from, is, the citation is down here. It's from the California Department of Public Health. It looked at death records of women all across the state for a 10-year period of time. And this is what they found. The vast majority of those women, 83%, died 7 weeks to 1 year postpartum. Your last OB visit is 6 weeks, right? And your Medi-Cal cuts off at 2 months. Now, that has been changed. You can extend it for a year if you're diagnosed with a maternal mental health disorder, but the uptake on that has not been great. So clearly, when these women fall out of the healthcare system, that's when these suicides tend to happen. 2/3 of them had mental health diagnoses before pregnancy. The rest had new onset. About half had depression, followed by psychosis and then bipolar disorder, and many of them had co-occurring substance use. This next one is the really important one that I want you to know regarding IPV. 83% had intense psychosocial stressors, including IPV. The stressors were typically a fight with a partner, and there was often some kind of financial stress involved. Right? So these things clearly are tying in together, IPV, PMADs. And 50% could have been prevented. There was a good to strong chance of preventability because there were opportunities to intervene, and it just never happened. Just a word about substance use. This is from the National Survey on Drug Use and Health from 2018. It looks at basically exactly what it says, past month substance use among pregnant women. And you can see that tobacco, interestingly, is the highest. And tobacco has actually the worst birth outcomes of anything else. Yet we don't talk about it. alcohol, and then illicit drugs. And you can see that the vast majority, it was marijuana, opioids, and cocaine. Now, what's missing from this list that we see in LA County all the time? You can shout it out. Somebody, unmute yourself.
Meth.
Thank you. Meth. Meth, meth, meth. I feel like some days I feel like I run a meth clinic. So much meth. So we'll get to that in a second. First though, this was a really interesting study to me. Lots of women use marijuana. I see this all the time, and people don't even like register anymore that it's potentially an issue, because since it's been medically legalized and now kind of, you know, every way legalized, women don't even think of it really as a street drug, particularly much younger women who kind of have grown up this way. The reason women use it primarily in pregnancy is to relieve stress and anxiety, followed very closely by nausea and then pain. The one thing that is not on here, and I am convinced that it's just because they didn't ask, is insomnia. I cannot tell you how many women I know who use marijuana for insomnia. And the fourth reason, or fifth, if you want to add insomnia in here somewhere, is to have fun. That's not really why people are using it. People are using it because all their other kind of concerns aren't being met in other ways. So look at the rates here, how much higher it is than everything else. Okay. So one thing that we try to do in clinic, and we had a new intake yesterday, a woman who, you know, second baby, she's now postpartum, that she smoked all the way through and she used marijuana all the way through. So the main reason why she used was anxiety and insomnia. And that is very consistent with what we know. So we're trying to address those things with her to decrease the marijuana use. It's also important to address withdrawal symptoms, and then really try to help her feel well overall so that there's a reason to no longer use. Meth use. Okay, this is my one slide on meth use. This is another one that I could talk your ear off, you know, about forever. One, we don't know much about it in pregnancy because it's very hard to study. Who wants to cop to it when it means their kid is going to be taken away, right? What we do know is that meth use has seriously escalated in the past 2 decades. There's more attention given to opiates because A, we have treatment for it, medication treatment, and B, just the way that it's rolled out as a pharmaceutical, and, you know, there's been lawsuits against the pharma company and all of this, and opiates are god awful. I mean, it's been a horrible problem. In our corner of the universe, though, it really has been more meth. In just this fourth bullet point down, from 2005 to 15, the percentage of women that injected went from 2% to 30%. And from 2010 to 2014, overdoses involving meth have doubled. And what's really interesting, the mortality with meth is very, very high, but women die at much higher rates because of meth than men. Why would that be? Anybody want to throw some stuff in the chat? Anybody want to guess? There's no like one right answer. Oh, thank you. Someone, but I have no idea, but very curious. Okay. Body weight. Yep. Women become very thin, very frail. Yep. What happens if someone, so here are some things that happen, right? One is overdoses, right? Another is women are often in positions where they are sexually vulnerable, right? Because folks with meth addiction that becomes really problematic often end up homeless. They often end up without financial resources. So trading sex for money becomes something that people do. That leads to violence. It leads to STI, sexually transmitted infections, right? It leads to a general lifestyle that reduces lifespan, basically. But it's that violence, that vulnerability to illness and infection that really, yes, make a difference. And someone else put abuse, yes, trafficking, yeah. So there's a lot that goes on there with meth use that's highly, highly concerning. Okay. Any questions before I talk a bit about disparities?
No, but there was 2 comments that I think that I would like to share with you. So Priscilla put, so far listening to this presentation, teen mothers have been in my mind a lot. Teen mothers dealing with IPV and family abuse, and they are not, and they are just labeled as bad teen moms and not getting diagnosed and receiving the support they actually need. So that was one. And then the other one said, thank you for shedding light on mental wellness dilemma in general. It is very much misunderstood within IPV SA community, and for identifying the risk and protective factors for pregnant women or women looking to become pregnant.
Yes, so yeah, we need to just keep shedding light on this for sure. And I thank you for that. Teen mothers, absolutely. And I've seen a lot of very young women between 18 and 21 who are still in the foster care system and get pregnant. And so there's a phrase for it. I forget what DCFS calls it. It's like, it's not parenting teens, but it's something like that. And they do get some support through DCFS. But what always tugs at my heart is how 9 times out of 10, those young women want to be so different from what they knew growing up. Like, they want to be a good mom. And of course we want that for them. And what it takes to help them parent, to role model, to support. I don't know what all is out there for them in that regard, but the desire is there on their side. So there is, again, in pregnancy, there's that moment of kind of intervention for those young women who have that desire, yeah, not to be labeled like bad moms, but to move in that direction. Okay, say a bit about disparities. Okay, so how common are PMADs in general? So the average rates of perinatal depression in the US are about 1 in every 8 to 10 women. But anxiety is actually even more common. It's about 20%. And like I said earlier, postpartum psychosis affects about 1 to 2 out of every 1,000 deliveries. This is from LA County. And this is data from the LA County Department of Public Health. They do this survey every couple years. So this is self-report. This isn't like formal diagnosis. This is women saying, yes, I had some kind of depressed mood in pregnancy or in the postpartum. So pretty solidly 25% of women responded in the affirmative that yes, they had some kind of depressed state during this time. Black women by far had the highest. If you look at pregnancy, rates of depression in pregnancy for Black women, it's pushing 40% and 28% in the postpartum. Latino women were next, though their rates are closer to the LA County average. And then white and Asian women were sort of neck and neck. So there are 2 things about this that are striking to me. One is that the rates in pregnancy were as high or higher than the postpartum. And the second is how high rates were among Black women. And this is kind of an interesting paradox for Black women as well when it comes to IPV. So I don't feel very qualified to talk about this, but as I was reading about this to kind of prepare for today, this really struck me. And that was, if you are a Black woman who is in an abusive situation, but you care for your partner, do you call the police? Right? There's a fear, right, of unjust harm to their partners because maybe of racially motivated actions on the part of the police. We know that there's disproportionate incarceration of Black men, but also a sense of like, well, if I even call the police, does it matter? Right? Will anything happen? And not only will the judicial system pay attention to me, but will my own community pay attention to me because I called out my partner? Right? So there's a lot of it's a conundrum for women in this situation. Yet pregnant Black women are killed by their partners. This stat just blew my mind, at 8 times the rate of their non-pregnant peers. That's astounding. That is astounding. I wanted to, you guys, if you're listening, which is always an if, but if you're listening and you've heard of the AIM initiative, raise your hand. I can see people raising their hands. It's a good opportunity for you to let me know you're out there, but also if you've heard of the AIM initiative. Okay, Kay's heard it. Okay. So, all right. So the AIM initiative is something that I think would be a really important group for folks to be aware of. It's run by it was actually started by the Department of Public Health. But what it is it's a group focused on reducing the disparities in Black babies' deaths and Black mamas' deaths in LA County. So this is the data that kind of got it going. So if you look at, this is infant mortality, okay? Look at these rates. So white women or white babies are the blue line, API is the yellow line, Latino is the gray line, and then orange are African-American or Black babies. The rates of death are 3 times higher. Black women's deaths in labor and delivery are at about the same rate. And so DPH just said, not okay, we need to do something about this. So they started the AIM initiative. It is a community-based effort with focus on service area 1 and service areas 5 and 6, or excuse me, 6 and 8. That's where it started. Now it's in most of the service areas around the county. And their goal is to close the gap in maternal and infant mortality. Their strategy is to do this by reducing toxic stress. So the toxic stress of mental illness, the toxic stress of IPV, the toxic stress of racism in the medical system, any kind of toxic stress, micro or macro, that is affecting Black women can reduce like good outcomes. So the idea is to get rid of that toxic stress and close that gap. So one of the emphasis is on increased social support as protective measures. They have sister circles, which are kind of like support and education groups, and a doula program. But there's certainly room for anyone who is interested in being a part of this effort to join up. So if you just go to the DPH website and look for AIM, it'll take you there, who to contact, all that good stuff. And if you can't find it, I'm going to give you my email at the end of this presentation. But I would encourage any of you who are interested to reach out to the folks who are on this and see how to be a part. There's one other stat I wanted to throw up here because it blows my mind. As you know, there's a lot of homelessness in LA County. And there was a survey that was done recently that said that up to 70% of the women in Los Angeles who are homeless cite IPV as the cause, as the reason they left. And many of them left their abuser in pregnancy. Mental health symptoms, obviously, are also substantially higher in people experiencing homelessness. So again, IPV, mental health, pregnancy, that trifecta of stress and crisis also can lead to homelessness or worsen women who are already struggling with homelessness. Okay. So after having gone through a lot of really not so uplifting slides, I'm going to talk about some points of intervention.
Dr.
Yeah.
Sorry
Yes.
to interrupt, but before
Yes.
you continue, in the past segment that you had, someone was asking about if there was more current data. I'm assuming it was back to the prior data you were showing, if there was anything more current. Was one of the questions. And then the other one is, how do you handle the issue of mandatory reporting?
Okay. Current data on what specifically?
You didn't specify. Kimberly, it was Kimberly Perkins. I don't know if you would want to speak up, Kimberly, or want to put it on the chat. what data you were
Yeah,
referring?
no, hi, good morning, everybody. You just referenced the data from, I believe, you had on there, you pulled it from 2016.
Yes.
Yeah, so I was just wondering if people are working on updating it, and because it's a little bit outdated, so
It's a
I'd be
little
curious.
outdated. Yeah.
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 Just
Yeah.
curious on that.
That's a great question. They do it every 2 years. So presumably they did it in 2018. I don't know. I think DPH was a little busy in 2020. But I don't know. So it takes a while for the report
Gotcha.
to come out. So I don't know if 2018 could have been posted yet, and I just hadn't seen it. But the last I looked, it had not been posted. But yeah, it's a great question. And there's some conversation about if they're even going to continue this survey, because it's not like super rigorous data, but I think it is a helpful kind of snapshot of what's going
Gotcha.
on.
Yeah, it gives us kind of the meat without the potatoes, I guess, if you will.
Exactly, exactly. And if you go to their website, DPH website, they have the full report, and that's actually more helpful because they have it broken down. It's like all kinds of factors that affect perinatal women. It's not just mental health, and it has it broken down by service area. I pulled out the race and ethnicity piece. They have it by supervisor's district. They have it in lots of different ways. So you can kind of see, if you have a more specific question.
Right, gotcha. Yeah, I am in SPA 1, so
yes,
we're the star children, unfortunately, in the disparities up here in the Antelope Valley. I mean, it's all across all spas, but yeah, we always seem to make number 1 on the list, unfortunately.
Yeah.
Thank you.
Yeah. And then how do you handle the issue of mandatory reporting? For DV specifically? So, we report if we have to, obviously. A lot of times the reporting that we end up doing is actually in the postpartum when there's a child involved. And we have to make the report to DCFS. That's often how we end up having to do the mandatory reporting. Because we work in OB, and often in pregnancy, the reporting involves documentation of injuries and things like that. It's often OB that actually does the mandatory reporting. But in the postpartum, we usually do the DCFS reporting. I don't know if that's helpful. I struggle with it. I think everyone does.
I was just going to affirm that. I think we all do. And I know that, at the medical center, it's something that reporting is taken very serious. But I did want to point out Ellen's comment that LA County Health Survey is going to begin again in 2022, and that there is LA County data for 2018.
Okay, great. Thank you. Hi, Sherry. It's fun to see names I know on here. Can we get the websites you recommended, RA perinatal support? Yeah, I put them up in the chat. If you scroll up in the chat, you should see them at 9:33. I put them in. Okay. All right. Oop. So I'm going to talk about points of intervention. So the exciting thing about this is a lot of these things are already happening. Some aren't, a lot are. And so a lot of this is actually around kind of recognizing what different people are doing and trying to link up and then kind of strengthen and or augment. And what's also interesting, I did another kind of similar conversation a couple of weeks ago with ICANN, the Interagency Council on Child Abuse and Neglect, and it's like all the same recommendations. So there's an evidence base behind these. It's not rocket science. And like I said, lots of folks are doing these things. It's a matter of pulling people together, which is in LA County way easier said than done. But here we go. The thing that is so exciting to me, and like said this earlier, and this is what I want you to leave with, is that the perinatal period is a window of opportunity. And I love my job because I see women transform. I really do. And it's so awesome. I had a woman come up to the clinic a few weeks ago. I barely recognized her. I worked with her 5 years ago. She was so depressed through pregnancy and the postpartum. Now she's a nurse. She's an LVN at the hospital. She got her degree. Her baby is 5. He's crushing it. It just was like, made everything worth it, right? Like that perinatal period, she left her abuser back in her home state to come here. She made it happen. And so it is just so exciting to see that. Women are motivated. And sometimes they don't show up until month 7 or 8 of their pregnancy, when they really, it's undeniable, that they're pregnant, but they are willing to make changes. Also, they have the opportunity to have frequent and regular contact with healthcare professionals, but also the services that have come to be a part of a lot of our county healthcare, right? So like the Mamas program, which I'll talk about in a moment. But women get Medi-Cal when they're pregnant. It doesn't matter if they're incarcerated. It doesn't matter if they are quote unquote illegal immigrants. Like they have Medi-Cal. They have Medi-Cal in the postpartum briefly. So there's a moment in time where we actually can connect with them. And many women of childbearing age don't go to the doctor unless they're pregnant. So it is an ideal window of opportunity, and it gives providers a chance to investigate risk behaviors and really think, could this be IPV? Or could this be a PMAD, right? If someone comes in and they're still using alcohol, they're smoking, there's drug use, what is that about? They're smoking marijuana every day. Okay, did they just like to smoke marijuana, or are they dealing with anxiety? Or are they dealing with a stressful situation at home? So we're able to see those risk factors and investigate them. And then prenatal care providers who actually do physical exams can look for signs of potential IPV, right? Does she have STIs? Are there sexual problems? Is she having frequent miscarriages and induced abortions? Another thing that I didn't put in here, actually coerced pregnancies, like this young woman who came in yesterday, 10 weeks pregnant with a 10-month-old. Do I know if she wanted to get pregnant or if this partner forced her into it? I don't know, right? But that's a red flag for me, for sure. So there are physical signs of potential IPV that we can keep an eye out for. There's screening that we can do for depression and anxiety in perinatal women, as well as for IPV. We can do it early and we can do it frequently throughout pregnancy. So a very common screening tool for depression and anxiety is the EPDS, the Edinburgh Postnatal Depression Screen. What we use throughout the county system is a combination of the Patient Health Questionnaire 9, which looks at depression, and the GAD-7, which looks at anxiety. So every woman who comes in gets that very regularly, like at every visit, and we're able to, no screening test is perfect, but it does give us an eye out when women are struggling. But it's not just screening, right? It's following up those screening tools with questions and complete clinical interviews if they're indicated, right? Just doing a screening tool in and of itself is not helpful. I remember when I was pregnant 15 years ago, 16, I suppose, and I went to my physician and I was screened with the PHQ-9. And of course, I was curious about it because I was doing this work back then too. And I said, well, where does this go? And they said, oh, it just goes to an office downtown. I was like, awesome. Like, what if I'd circled the question about suicidality, right? We have to follow these screening tools up. And thinking about prevention, when it is safe and appropriate, incorporating fathers into these visits can make a big difference. And that's one thing that has not happened in COVID. And that is a shame, because bringing fathers in, helping them feel a part of it from the very beginning, and certainly in pediatric visits as well, can make a big difference so that it's not just mom and baby on one side and dad over here. When we then see that a woman is struggling, right, with a mental health concern or substance use disorder, or she's in a domestic violence situation, there are treatments. I mean, obviously with DV, you guys know this better than I do, that she needs to be safe. She needs to be, there's certain things that need to be in place first. But when she is in treatment, there are excellent trauma-focused therapies that make a big difference. There's a type of therapy called interpersonal psychotherapy. If you want to look it up and you're interested, it's short-term, it's manualized, you can get trained online. It makes a big difference. And then women really struggling, you know, we treat women with medications as needed. And the risks of the medications are, depending on the med and depending on the woman, are often far lower than the risks of letting her stress levels, her mental health concerns go untreated. So one thing I'd also like you to say, this is my plea to you as a psychiatrist, if you have a pregnant woman and she's on meds, don't, you know, knee-jerk tell her to stop. Right? I've seen way too much tragedy happen because of that. She needs to actually get in to see, she can come see us. She needs to see somebody who can advise her one way or the other. Another point of intervention, and I actually would love to know this from you guys, family-based counseling. And again, this isn't obviously appropriate for every family, but for a family that's, you know, in crisis or at risk, where it is appropriate, I have no idea where to send them for family-based counseling or couples counseling. Like, we don't do it at SC that I'm aware of. When I was at DMH, I never found anyone who did it. So if you guys know of anyone who does this, that's in the Medi-Cal kind of insurance business, I would love to have those resources. Because
Emily, if I can just share with you real quick.
Yes.
Recently in this past, I guess it's been a year now, we began to address family-based counseling. We actually received some funding to work with the entire family. And then through our Engaging Men and Healing Men program, through our men's circles, we also work very closely with many of the people who cause harm and helping them understand how it is that their trauma and, you know, just their life experiences and perhaps even their own mental health struggles has brought them to the point of that they're in their relationships. And then we, of course, you know, refer out for anything else that's outside of that realm. But the beginning stages of this process, we can definitely help navigate people in the right direction, whether it's the person causing harm or the survivor, and now even the children as well. So you can once again send them our way.
Okay.
And it's a huge gap. I know it's a huge gap, but
it's a huge gap. Yeah. No. Okay. Good. Well, we'll talk more.
Right.
I'm gonna come find you at SC.
Yeah.
And figure that out. So okay. Awesome. So that's really good to know. And so just, you know, if there are others of you that do this and you want to throw it in the chat or
chat later,
right. Like I would love to know. Because I just, you know, it's just so important. And then, you know, another point of intervention is doing exactly what you guys do, helping abused women access information and seek assistance, right? So I included this in like kind of the list of evidence-based interventions, but you know, you guys are doing it. So on this one, I'm preaching to the choir, and I thank you so much for what you do. Okay, I wanted to speak a bit about other points of intervention and then the Mamas program, and then we'll take some more questions if you guys have them. So one thing that's really helpful in this kind of window of women accessing healthcare, accessing, you know, this system is there are what are called quote unquote health extenders, but really folks who are almost, or who are like better poised to provide support and ongoing continuity than, you know, the physicians are for sure. And this includes peers, community health workers, social workers, some of the nursing staff. You know, I know where I work, doctors kind of come and go based on schedules, but these are the people who are in the clinic consistently and do provide that continuity and support. And then another way to do that is actually through home visitation. And, you know, LA has a strong push towards home visitation. And their home visitors are typically, again, community health workers, maybe social workers, and they are usually educated around, you know, PMADs, around IPV, at least screening for it. So that is another point of intervention that I think is going to continue to get funding from the current Board of Supervisors. So having said that, I wanted to talk a bit about the Mamas program as a model, and also so you guys are aware of it. And like I said, there are folks from the Mamas program on the call today. So what it is it's a countywide program. It's run by the Department of Health Services. So it's been a part of the county hospitals, all of you, LAC USC, MLK, Harbor, for quite a while now. And it's also rolling out to the community clinics run by DHS. And the objective, it's in the Department of Women's Health, and the objective is really to lower rates of preterm birth by decreasing toxic stress in pregnancy. The idea is that, ostensibly the US has great medical care and interventions. And, if you need some rare surgery, like, we're your people. But our birth rates, our preterm birth rates are on par with, literally like Pakistan. I mean, it just doesn't make any sense. And the idea is because we have so much stress in this country around perinatal women. And so the program is offered to every woman, every prenatal woman who comes into DHS for care. Most of them accept, some do decline, and that's okay. And the very first step is that she's assessed by a community health worker, which we call care coordinators, on 8 different domains of toxic stress. Okay, so those are housing insecurity, food insecurity, substance use, tobacco use, chronic medical conditions, IPV, anxiety, and depression. Okay, and these are the things that studies show really impact stress levels and impact pregnancy negatively. There's a lot more to the initial assessment, but these are really the 8 domains of primary focus. And then based on that, a woman kind of gets a score sort of based on this assessment. And from that, she's triaged into the amount of services that seem appropriate for her, right? So low, moderate, or high intensity. And then from that, her care coordinator, her community health worker, kind of works with her to link her up to needed resources. And then follows up, right? So if she's low risk, the follow-up is once a trimester and then once in the postpartum. If she's moderate risk, then she gets contact or continuity every month from the community health worker. And if she's high intensity, then it's every week or as needed. And if she's noted to have mental health needs, then we have social workers in the clinic that can do the behavioral health assessment. We do a lot of the psychiatric care at the OB mental health program at LAC USC. I think we're the only site that has a psychiatrist right there. We're now expanding and doing more telehealth work to other mama sites. Like a woman who spoke earlier about being in service area 1, we're doing this a lot. Actually, we did 2 yesterday for service area 1. And then for women who are also the most high risk, they can be enrolled in another arm of Mamas called Mamas Visits, which is home visitation. And there's a team of a care coordinator, a community health worker, a psychiatric social worker, and a public health nurse for each spa. And during pregnancy, their goal is to link that woman up to clinical care so that she actually gets in and gets the prenatal care that she needs, as well as other resources. And then they also work with her for up to a year postpartum to help with parenting support, other physical needs, providing ongoing mental health work, et cetera. So the Mamas program is unique in that it really tries to meet each woman where she is. It's evidence-based, and we don't turn away anybody. And a lot of the home visitation programs have different eligibility criteria, which is totally understandable based on what the resources are, where they're located geographically. But Mamas takes all comers. So I just wanted to show you a little bit of the data around who Mamas sees. So from 2017 to last year, about 15% of women enrolled in Mamas had what we call serious mental illness. So bipolar disorder, psychotic disorders, really serious recurrent depressions. So that's a good number. That's a fair number. These are the rates for anxiety and depression. These are women who scored moderate or high on either the anxiety or depression score or both. And you can see that anxiety is higher. Anxiety is the blue bar. Depression is kind of the cream colored bar. But it's always hovering right around that county average of 25% that we saw earlier. What's really interesting is look at the intimate partner violence. This is again in Mamas. This says 2014 to 17, but it's actually to 2020. And these are women who have moderate or high scores on IPV. So the average, I'd say, is about 31%, probably 31%. So a little less than a third of women that we see overall. I don't have graphs that show the overlap, right? Are the women with IPV the women who also have anxiety and depression? My guess is probably yes. If you look again, the trend lines, oops, good gracious, my children would be appalled at me, my lack of computer savvy here. But if you look at the trend lines, kind of a drop to 2016, 17, 18, and then a rise again with anxiety and depression, similar thing with IPV. So in conclusion, I just want folks to come away with the understanding that these three experiences of IPV, PMADs, and the perinatal period are all linked in a potential cycle of worsening crises, but at the same time, pregnancy and the early postpartum do provide a window of opportunity to actively detect and address IPV and PMADs. And this is important not only for the parent, but also to break, this intergenerational transmission of trauma, violence, and mental illness. And we have evidence-based points of prevention and intervention. We just need to strengthen them and link them together. And I do just want to leave you with one story, and then I'll take some questions. This isn't her. This is a stock photo, but a young woman who came to us maybe a couple years ago now, and she had she used heroin. She was living on the streets. Her boyfriend was incredibly violent towards her. She had other children who'd been removed and given to her mother for custody. And then around the 7th or 8th trimester, she decided that enough was enough. And she'd been enrolled in Mamas. She'd been coming to see us for mental health concerns, though very erratically. But one day she had kicked it. I don't know how she did it, but she had kicked the opiate use. She was clean. She was straightforward in her thinking. She was depressed. She was having a hard time sleeping, but she said, I'm ready to do this. She engaged in prenatal care. She delivered a healthy baby. And then about a week after delivery, the baby went home with her. She called and said, I am really struggling. I am going to relapse. I am so depressed. I need help now. And fortunately, one of the nurses took the call. We called her back. We got her back on her meds. We got her into an inpatient rehab facility where she got to keep her baby. She stayed clean. She did that program for, it was 18 months. She actually got her other kids back. She got her degree, and now she's working and living independently, still sober, and has all 3 of her children. So she was really struggling with all of it: substance use, mental health issues, IPV, homelessness. And because of that pregnancy period, because she was motivated and the services were in place, she got her life back together. So, and now not only is she doing well, but her kids are too. So there is an opportunity there. Okay, this is my email. And I know we are out of time, but I will definitely stick around for questions.
Mm-hmm. So we have one from Kimberly. It says, is this the Mama's Neighborhood program? When you talk about that? Okay.
Yes.
And then everybody's just telling you, thank you for this amazing presentation that you have for us. And then there was one that says, what is the first step of intervention? Where do you start connecting the client to the referrals that they can trust?
So I think it very much depends on where the woman is. And if she's in an active DV situation and her immediate concern is survival, then I think the first step is to connect her to safe shelter if she's willing to go there, right? So the first thing you always have to do is make sure that someone is able to survive. So whether that's IPV and getting into a shelter, whether she's so mentally ill that she's acutely suicidal and getting her into a hospital or intensive care, the very first thing you have to do is make sure that they're safe. Sorry, my husband's trying to get in the door and my dog is barking at him.
So then,
and so trying to make sure that they're safe. Past that, typically it can take a while for someone who is either has a PMAD or is a survivor to develop that trust. So one thing that's really important is to have some continuity. So the idea behind the Mamas program is that they have the same care coordinator. My clinic, I make sure they have the same doctor. You know, with IPV, however you're set up, try to make sure they have the same case manager, social worker, and then connecting them to whatever the referral is. Do they need ongoing housing? Do they need, the trauma-focused therapy? Like, do they need childcare? Like, what is it that they need? And then letting the woman really be the driver behind that. So I hope that's okay, but it's like safety, continuity with the provider, and then letting the woman really, dictate what it is that she needs the most.
I think Katia wanted
Is that all the
question.
Katya, you're able to unmute?
Yes, hi, can you all hear me?
Yes.
Hi, Dr. Dossett, first of all, thank you. That was just a phenomenal presentation. I learned so much. Just to introduce myself, I'm Katya. I work with Ruth and Rebecca at East Los Angeles Women's Center. And
Great.
I think one question I'm having now after hearing your presentation is just something I marinate on a lot is kind of the unfortunate false divisions we have to make in our work sometimes, like that, for example, we at East Los Angeles Women's Center don't have the expertise to treat substance abuse, which is, true and requires a different level of care than someone maybe who's only experiencing domestic violence. And so I'm curious, after hearing all the stories you shared and the evidence on just co-occurring substance abuse as a way to cope with trauma, what, I guess I don't really know even how to ask this question, but where do you see that going in the next 15 years? And how do we begin to address that? Or have you seen programs that are doing a good job? Like when you said that the woman that you had worked with, the kind of success story you gave at the end, that she was able to get into treatment and have her children with her. I would love to hear your thoughts generally on that.
Yeah. No, I mean, it is just wild, and it was particularly hard when I was at DMH, because a lot of the folks at DMH, I mean, they're coming from mental illness, but 80% of them had substance use disorders. But like, I couldn't provide that treatment. We have to send them somewhere else for that. And so it just never felt like people were getting everything they need in one place, right? And so I think that there is a move towards, what's called like integrated care. And there are sites that try to do integrated care. Like the Mamas program is actually a great example, right? Like I work literally in the same suite as the Mamas program for USC, as well as the OB team. So we're able to do the physical, the service, social services piece, the mental piece, able to do all that. We have also a navigator so all substance use is run through Department of Public Health. We have a navigator that communicates directly with mamas to try to get people into substance use treatment as appropriate within public health, but then they stay connected to mamas and to us for mental health and their prenatal care. So right now it's a lot of workarounds, right? Right now it's a lot of workarounds. It's a lot of developing relationships with people in agencies so that you can try to integrate care for each woman as she comes along. Structurally, there's not really a great mechanism for doing that I am aware of. It also makes it hard because different agencies and services have different medical record systems. So like if I have someone come in, to a DHS program, like I don't have access to their DMH records. I mean, I do because I kept access, but I'm like the only one, right? Or if they were in jail, like I don't have access to those. If DPH has their own system. So there's a lot of information sharing that doesn't happen that I think is actually quite dangerous for patients. There is this sort of, what's called a realignment or a reshifting of how Medi-Cal is funding programs at a state level called CalAIM that is focusing quite a bit on trying to integrate certain aspects of care like mental health and substance use And there are going to be pilot projects that specifically focus on some of the most high-risk people and trying to make sure that all those services come to that person instead of the person having to go to all those services. That's going to be a long time coming, but 15 years, maybe we'll be there a little bit. But I think the barriers right now are a lack of information sharing, a lack of infrastructure for actually referring people back and forth, other than what individual programs or people are able to do. And it's difficulty in finding the appropriate funding so that, you know, one particular service program will actually take ownership. Is that helpful?
Absolutely. Yeah. I'm, this is where the work will be. And yeah,
where the work will be.
Yeah.
I mean, I tell people, like, I've been practicing psychiatry now for 15 years. And at this point, I don't really hear anything psychiatrically that shocks me anymore, but something about the system shocks me every day.
Amen.
Like, people tell me, you know, psychotic patients, people tell you stuff that my friends like wouldn't be able to believe. That's all par for the course. Dealing with the system is like next level.
Right.
You know, that's where the crazy is.
Yeah, absolutely. And, you know, and here's the part that's always challenging is we as providers have a hard time navigating the system for the clients that we serve. Imagine being a client trying to live within that system and you needing to, you're dependent on, they literally have a grasp on your life, and the outcome of your life depends on the decisions made by all of these people that sometimes don't communicate with each other. And, you know, but with that, I know that we're over time. We can continue on, but I did want to, I know that, you know, I want to be respectful of people's time. I can go on with this conversation for the next 2 hours, and I'm sure we still have a lot to speak about. You know, the East Los Angeles Women's Center has been responding to survivors in need of services at the medical center since 1979. It's only been within these last 10 years that we have really focused on partnering and educating the providers there on the correlation between domestic violence and overall healthcare, some of which you highlighted today. I want to thank you on behalf of the organization for being such a champion for this conversation. It is because of providers like you that we're able to further this this silence. We're able to start to crack open that door and really speak to what it is that the survivors are dealing with, and to begin to understand that providers, there was a Blue Shield study, I want to say about 10 years ago, there was a Blue Shield study that indicated that that while we would all like to believe that, you know, police officers and county social workers and the school system are friendly places for people to family to access resources, it is it's been detailed that 80% of individuals that were asked indicated that the first people that they would trust in disclosing violence in their homes is medical providers, which is why we've shifted so much of our attention to this area, because we understand that a relationship and a partnership with those of you who come in direct contact with survivors and have their trust are going to be sometimes the lifeline that they need to be able to access resources and safety for their families. So we cannot thank you enough, not only for this presentation, but for the many years of relationship and of trust and of understanding and of due diligence, and just making sure that all of these people that walk through your doors are being assisted and are really being cared for, and are being cared for in a dignified way, which is the most important part of this conversation, right? So thank you, Dr. Dossett. I would like to thank everybody who took the time out of their day to attend this. Needless to say, it was an incredibly informative and necessary and amazing presentation. We will be distributing this presentation. We'll also be posting it to our various social media. Dr. Dossett, if you have any last words that you would like to say here.
Just thank you guys for coming and sticking with it. And please, you know, I just think this is so much about relationship and connecting. So please feel free to reach out really at any point. And Rebecca, you know, I'll do the same. So thank you guys for what you do.
Absolutely. Shout out to Ruth Rivera for navigating that chat.
Thank you.
Thank you everyone for attending. We will send out this recording. You can share it with your colleagues who were not able to attend today. If you have any follow-up questions for Dr. Dossett or myself, please feel free to reach out. And that concludes our meeting for today. Thank you so much.
Thank you.
Thank you guys.
Thank you all.
Thank you.